easier. Good morning. I'm Dr. Myers. I'm the medical director of respiratory therapy, and I'm going to give you guys some information on your lung diseases. I know that most of the people in pulmonary rehab have some type of underlying COPD, but there are also many other diseases that are represented in the pulmonary rehab, including bronchiectasis and pulmonary fibrosis, and patients who are recovering from COVID. So hopefully this will be beneficial to all of you, but just know that the majority of this lecture is about COPD, as that's the majority of patients in pulmonary rehab. So what we're talking about today is something called an exacerbation. And what that means is that your underlying lung disease is flaring up. Something is triggering it, whether it's a cold, a bronchitis, a pneumonia, or just simply some other trigger that's flaring your lung disease. And that's what an exacerbation is. All right. So, okay. So let me see how I can advance my slides. I thought the arrow down would do it. None of those are working. Okay, Terry. Really?
If you slide that over the top here.
All right.
And then just like right
What
there.
if I do the actual presentation mode?
Yep.
Huh? Isn't there, yeah,
Right there.
this one?
Yep.
Oh, they went away.
Yep.
Okay, so that's the problem?
Yep.
Second. Here we go. Okay.
I can see them if they.
Can you guys see me? Okay, they can't.
Yes, we can see you, and we can see your PowerPoint. Yep.
All right, here we go. All right. So, what we talked about is that it's a flare-up of your underlying disease. So today I'm going to talk about flare-ups that occur in COPD, bronchiectasis, and interstitial lung disease, which means pulmonary fibrosis for the most part. So for a COPD exacerbation, the symptoms people may have is they may feel more short of breath. You may have increased sputum production. You may notice actually a change in the mucus that you're coughing up. Some people may have fevers. Some people may feel some chest tightness, and some people may just feel some fatigue. And so there's a whole spectrum, but the bottom line is that it's a difference from your baseline, okay? This little diagram that we have here is a picture of an airway. Well, you can see the person's coughing, and this is a segment of the airway which would be normal, and an airway that's all inflamed with some mucus coming out of the edge of it. That's what that's kind of showing you. And you can notice that if the airway is full of mucus and is inflamed, it's harder to breathe through that tube. So an exacerbation is typically a clinical diagnosis, and what we'll hear if you were in clinic or you're seeing your primary, that you may be wheezing, we may not hear a lot of air movement, that you may be using more muscles in your chest to breathe than usual, which are called your accessory muscles. If you have a little SAT monitor, you may notice that your oxygen saturations are running a bit on the lower side. We may see that you're breathing faster. You may feel that your heart is racing in your in your chest. You may be weaker than usual. And for some people, and this is really more of a medical emergency, your level of consciousness may be a little bit down, or you may be confused, and a loved one might notice that. All right. So in terms of how we make the diagnosis, sometimes people will get a chest x-ray, although often it's just made based on symptom changes with COPD. Sometimes you might get a sample of sputum. In the winter months, we may test for influenza, and everybody's getting tested for COVID now. Even if you're vaccinated, there's certainly a chance of breakthrough disease. Some people may really step it up and get a CAT scan of the lungs, but that's typically not used for a COPD exacerbation. And so the other thing that's helpful is this thing called a COPD action plan. And you guys may have this. And what it is it's a diagram that a piece of paper that you have at home. And it's a tool to use to help you know, are things worse? What do I need to do? What's the plan? And so, you know, the green section is this is what I do when I feel good. So this is where you would put your maintenance medications in and how you take them. And green basically means you're feeling good. Yellow means I'm not feeling as good. Something's not, I'm off my baseline. And then again, what would you do at that time? If you've got a nebulizer, you may start using your nebulizer. If you have a rescue inhaler, you may use that more often. This is kind of letting you know that I need to be stepping up what I'm doing at home because I'm feeling like things are worse. And then the red zone, the red zone is when I feel really a lot worse and I really can't breathe very well. Do I need to go to the emergency room? Do I need to contact my doctor? Do I have a plan in place at home? Some people will have backup steroids and antibiotics that they have on hand and a plan that they've drawn up with their doctor to say, when I'm not doing as well, then I'm going to take these medications. And then if that doesn't work, then I definitely need to go into the clinic, urgent care, or the emergency room. And so hopefully you guys have one of these and can review it either with your primary or with your lung specialist in terms of what you need to do if you're getting into trouble. So the things that cause flare-ups of COPD are going to be viral infections most often, can be bacterial infections. For some people, it's a change in the weather, such as it's really humid or it's very cold. Pollution or particulates in the air. So we had all these fires up in Canada and that smog that moved across Minnesota. A lot of people had a hard time breathing during that time. Sometimes actually it can be a stressful event that can trigger a COPD exacerbation. And sometimes if you have other issues like heart failure and COPD, if you have a worsening heart problem, that can affect your breathing as well. And certainly if you have any heart rhythm issues and your heart were to go really fast, that could also affect your breathing. So these are some of the things that can cause flare-ups of your COPD. So how do we deal with that? So oftentimes the first line is if you've got a rescue inhaler or you have a nebulizer at home, to step up the frequency of how you're using those. And simply just doing that can help ward this off from becoming something worse. If you have a backup plan at home with steroids and antibiotics, you could use that. Or if you need to come into the clinic to be assessed, more often than not, COPD exacerbations are treated with a round of antibiotics and steroids. Some people just need something to help with the mucus, and you can buy something over the counter called Mucinex or Robitussin. But in general, to have a plan, especially if you have frequent flare-ups, is a good idea. Some people have something called a flutter valve at home, and what that helps is that helps clear out some of that thick mucus that you're struggling with. And some people who have really quite severe disease will have a vest at home. And I'll show you a picture of what one of those are. Some patients who have really frequent flare-ups may even get this thing called bronchoscopy. And this is what this looks like. This is a fiber optic camera that we get down into your lungs to help clear out mucus. And typically this is only used for patients who are in the hospital or patients who have a lot of flare-ups and associated with a lot of increased mucus production. Bronchoscopy can help clear that stuff out. The other thing that I mentioned is something called a vest, and it literally looks like a vest that wraps around you, and the machine off to the side generates pressure that goes through that tubing, and you kind of get shaken up like a um, uh, it's a device that shakes your chest in an effort to basically move that mucus that is more in the periphery of your lung more into the central area so that you can then maybe clear this out of your lungs better. All right, so that is what a vest looks like. And these are the flutter valves. And most people in pulmonary rehab will be introduced to this thing called an Arabica, which is also the most widely used flutter valve in the Park-Nicolet system. And it can also help you get that mucus out by breathing. And again, the respiratory therapy class will teach you how you use this to help actually get that mucus out, because the technique is really important. People have really bad exacerbations and end up in the hospital, may end up on something called a BiPAP. And this is a machine that's basically an external ventilator. And it's a tight fitting mask that goes over your face. And it basically helps to support your breathing. So every breath that you take gets supported. So if you're really tiring out and feeling weak and you're just having a really hard time breathing, we know that BiPAP can help offset that work of breathing. If your carbon dioxide level has gone particularly high, it can help you blow that off through breathing, taking deeper breaths and getting that air, that byproduct called carbon dioxide out. Some people have something like this at home. It's called CPAP, and it's used for sleep apnea. But this machine that's called a BiPAP just actually does more work than a CPAP machine does. All right. Now, what if you got really sick and you were hospitalized with your COPD exacerbation? You may end up on something called life support. And the medical word for this is intubation and a mechanical ventilator. So this person, he looks really comfy because he's asleep, but he has a machine that's going down through his mouth into his lungs. And there's a machine here called life support that's breathing for him. And that's a very extreme exacerbation of COPD, but it does happen. Patients do end up on life support, and you know, some patients certainly, depending on the severity of the disease, are able to come off life support if they got that sick. For some people who get so very sick and end up on life support, they don't ever wake up, and you know, it's a different conversation there in terms of coming off life support and passing away. I think these are really important discussions to be having with your doctors. We're hearing a lot about ventilators now because of COVID, and a lot of people, despite everything we're doing for COVID, are passing away despite life support. But I will say that people with COPD who end up on ventilators, certainly patients can come off life support and have meaningful recovery. So I just wanted to put that out there, but it really speaks to how severe things have gotten if you end up on life support. Okay, so what is the most important take home also from this is that if you have a bad flare up, you have a bad exacerbation of your COPD, the most important thing is to go to pulmonary rehab or to go back to pulmonary rehab. And that we know that the biggest intervention we can do in anybody who has a bad flare up is help build back that muscle, the endurance that's lost with the flare up, because people who have exacerbations end up on the couch. They end up in bed. They're not moving around, so they're losing muscle mass. They're losing their ability to their cardiovascular fitness. And so it's really important. I'm glad you guys are all in pulmonary rehab, but anytime you have a flare up, you need to go back to your books that you're given. You need to ask for a referral back to pulmonary rehab. Or again, if you've got some equipment at home, pull out all the literature and books that you've been, you know, the binders that they give you to take home and work on that exercise at home. All right, so that's COPD. And now we're going to talk a bit about bronchiectasis. So bronchiectasis is a different disease to COPD, but the diseases do overlap, and some people actually have both. So bronchiectasis is a problem when in the actual windpipes getting a bit floppy and losing some of their elastic recoil. So mucus tends to really plug up the airways, and people get colonized with a lot of different types of bacteria and are more likely to need antibiotics with every flare-up. So when someone's having an exacerbation of their bronchiectasis, they will also feel short of breath. They may have some chest pains that we call pleurisy. Certainly, there's an increase in the sputum production and oftentimes a color change. Some people with a flare-up just feel run down and fatigued and their appetite's down, and recognize that this is a flare-up for them with their underlying disease. So this is a picture of a CAT scan, and people who have bronchiectasis, these black areas are your airways, are your air sacs, and these white areas that are all dilated, those are the windpipes that are dilated and filled with mucus. And this is kind of at the bottom of the lung. And again, being able to see these airways so well outlined in white, we know that this is mucus-filled airways, okay? So the tests that we use, oftentimes we'll get a chest x-ray or a CAT scan, will help us show that things are a lot worse. We do like to get sputum samples because oftentimes patients are chronically colonized with certain bacteria, and we can tailor the antibiotics to that specific exacerbation. Again, in winter, nasal swab for influenza. In this time of the pandemic, any kind of worsening of symptoms, even in patients who are vaccinated, we need to think about COVID. All right. So treatments, same thing. Oftentimes we increase the frequency of their nebs. We have antibiotics that are targeted against certain bacteria that tend to grow out of their lungs. Patients with bronchiectasis are definitely using a vest or a flutter valve to help with secretion management. Steroids are not used as often, but some patients do respond to steroids as well. And then again, back to this idea of bronchoscopy. Again, when you have so much increased secretions in your lungs, sometimes you need what we call a clean out, where we go in and suck out as much mucus as possible with a bronchoscope. Patients with bronchiectasis can also have that action plan where they know when to start up antibiotics. They know when they need to come into the hospital just because they're flaring up. Again, a referral to pulmonary rehab is really important because you lose strength, you lose muscle mass every time you get sick and are lying around in bed trying to recover. All right. So what about interstitial lung disease? And again, if you guys are asking, well, what is that? This is for people who have this disease called pulmonary fibrosis or some other type of scarring pattern on the lung. And again, there may be people in the audience don't have that disease, but again, a lot of these disease symptoms overlap each other. And patients with a flare of their pulmonary fibrosis may have increased cough, shortness of breath, worsening oxygen saturations. And oftentimes people who have this disease called interstitial lung disease, they also have some other diseases like rheumatoid arthritis or a mixed connective tissue disorder. And so sometimes their joints flare up also, or their skin flares up, and these are, the whole body is inflamed, and that's including the lungs. So when people have a flare-up of their interstitial lung disease, oftentimes we need to move quickly to bronchoscopy because they're chronically immunosuppressed. They may need certain different types of antibiotics. We may need to look for other medical issues, including looking for blood clots or heart issues. And we can do that with various imaging tests and cardiac stress tests. Oftentimes people with interstitial lung disease are already chronically on steroids, and they need a burst, and their numbers need to go really high with a slow taper to get their disease back under control. Certainly, if they have an infection, the antibiotics are warranted and are targeted against the usual things that grow out of their lungs. All right. And the common theme to all these diseases is that going to pulmonary rehab to build up strength that you've lost during your flare up is really important. Again, some people use up all their days in pulmonary rehab, but you are given instruction manuals on things you can do at home. And I would really encourage you that anytime you have a flare or what we call an exacerbation of your underlying disease, that you refer back to that. And even if you're tired and you don't want to get out of bed because you're like, I don't feel good, I'm not breathing as well, pushing yourself to exercise is really key. All right. And I'm going to open this up for questions. And just give me 1 second to change screens.
And I will unmute everyone.
Quick exit. I don't know. Okay, there we go. Let's see if I minimize that window. There we go. All right. So I'm going to open this up and just, there we go. So you guys are unmuted now and can ask questions. And I will see if I can answer them. Okay, people aren't unmuted.
I know I can't.
Let me see if I can do it. Is there a way to unmute participants? There we go. I think if we just
You might
click.
have control.
Yep, let me do this. Mute all. Nope. All right, I can't. I'm going to. So Carl, you can hit that. There's a little mute button. You can click it on your screen and it'll open it. Same for you, Phil. If you look at your screen, you can touch the little microphone, which will then unmute it.
The wall and sit in the squat position.
All right. So you guys can just speak and then I can hear you.
Can you hear me?
I sure can, John.
Phil Johnson here.
All right, Phil, I can hear you. And Lisa, you want to say something?
So we have two
Oh.
participants on 2 other computers,
Okay.
and they don't have questions right now.
Okay. Well, Phil or John, do you have questions?
Not that I can think of right now.
Okay.
I thought I did, but I can't think of it.
Okay.
No questions here.
No questions. All right. Well, thank you guys for listening in on the lecture. I hope it opened up your eyes to just some of the things that you guys can do to empower yourself to stay on top of your disease. And again, that COPD action plan is very helpful for some patients. And, you know, having the conversation with your doctor about, you know, what can I do when I have a flare up, just kind of helps keep, you know, kind of empowering you guys to stay on top of things so things don't get bad and you don't get hospitalized.
This is John. I do got a question. The last time I went up to see Dr. Miller, she looked at the CT scan because you brought up emphysema on the last session here. And, you know, I really don't have that much of emphysema, but I'm wondering about this bronchitis. I've never talked to anybody about that. Is that something my primary care could answer? Whether I got bronchitis?
So certainly, you know, you and Dr. Miller can talk about that more, but so COPD, which is chronic obstructive pulmonary disease, which is having repeated episodes of bronchitis, and emphysema do overlap. People who have smoked for a period of time can develop emphysema when you.
Well, I guess I'm okay with the emphysema. Is the bronchitis and COPD, is that the same thing?
No, they're actually different. So the emphysema is happening in the little air sacs and the bronchitis is happening in the little windpipes. And some people get both and some people just have one or the other. There's really no treatment for emphysema. The best thing you can do for emphysema is to stop smoking.
Yeah,
Because
I've
then,
done that a while ago.
yeah, then emphysema stops progressing. But for the chronic bronchitis, we have those inhalers and we've got the nebulizers and if you have an exacerbation, steroids and antibiotics.
So Dr. Miller says my emphysema is not really much.
Yeah.
So what I got is bronchitis mainly.
Okay.
Is that my problem?
That's probably your problem. And then getting on top of it to help keep the secretions out of your lungs and to help keep you healthier would be the goal.
And my primary care doctor, Dr. Hebel, would she know pretty much whether, about my bronchitis, whether I got bronchitis symptoms or
I'm sure
emphysema?
your primary could manage this too.
Okay,
Yeah.
guess that's it.
All right.
Dr. Myers,
Yep.
I'm going to put this mask down. I just want to make a comment, if I could.
Sure.
The doctor that I see and the staff and the respiratory people here are wonderful, but it's very frustrating trying to get an appointment to see your doctor because they're months out. Is that being looked at?
So there's often an access problem. And what I would say is that a lot of things like COPD and bronchiectasis and bronchitis can be managed by primary care. And using the subspecialty care like the lung doctors should complement your primary care doctor, and your care shouldn't just shift, even though you have a primary lung problem. The idea is that we are working with your primary care doctor so that if you acutely need to get in and you can't get into pulmonary, you have your primary to see. And if your primary cannot manage it, they will contact us. But in terms of access, I mean, this is a problem throughout, patients prefer, they're like, I have a lung problem, I just want to see my lung doctor. But really the idea is that we're trying to get you to sort of to come up with a plan so that if you are acutely worse, you can still see your primary. And then if they can't manage it, then they call on us, is the way to think about it. And unfortunately, there's the opposite happens where patients feel like, well, I have a lung problem, I should just see my lung doctor. I can't get in, I'm frustrated. Then I would say, keep trying to get in to see your primary and have your primary, if they cannot manage you, contact us.
Okay, I was told by pulmonary that pulmonary should manage my case, not primary.
Yeah.
Well, then if they told you that, then again, I don't want to get in the middle of that one. There's just so many pulmonary providers and there are a whole lot of primary care doctors. So I don't think the access problem is going to change. I think with the pandemic, a lot of us got pulled into the hospital. And so the numbers in the clinic went way down. But that's not a problem anymore. So other than that, I'm not, I would then call and if you were told you need to see your pulmonologist, then, I would say, please put me on a callback list or see if I can get worked in to see one of the nurse practitioners, or if there are any openings, work me in to see my primary pulmonary specialist.
Okay, thank you.
Sure.
And I just thought of the question I had. I kind of followed this because originally I moved up here, the Kansas City area, Missouri. And you're familiar with the problems they're having down there with the Delta virus or this offshoot of, I guess, because people have been getting vaccinated, their rates real low.
Yeah.
What's the chances of that happening up here?
So what I'll say is the Twin Cities numbers are quite good in terms of vaccination. I think we may be as high as 70% in the cities. As you go more rural into more rural Minnesota, vaccination rates drop off for the same reason they have dropped off in Mississippi and Florida and Alabama. There's a big distrust and there's a lot of
Well,
poor information out there about.
I guess for the state of Missouri, it was like in the low 40s, the whole
Yep.
state, that people they got vaccinated. Most people haven't.
Right. And so we are all disappointed that there's been such a bad misinformation campaign about the vaccine. We know that this vaccine is saving lives. The people who are getting sick now and getting hospitalized are almost uniformly
Yeah,
unvaccinated or people with immune problems that
Yeah.
didn't respond to the vaccine. So it does put everybody else at risk because we know that there are breakthrough people who were vaccinated are still getting the disease. The good news is they're not getting nearly as sick as unvaccinated patients. The problem is that as long as the virus is in the community, it's going to keep mutating. And so in time, even though you stepped up and had your vaccine, it may not be effective. And so all these people who are holding out saying, I'm not getting my vaccine because it's my right, are actually setting everybody else up for failure. And this is just, it saddens the whole medical community that there's been such a misinformation campaign out there. And so, but clearly we know this vaccine works.
Yeah.
And so I would just say, if you have any family who is hesitant, it's good to just tell them your story. And, sometimes that is helping people move forward and move away from hesitancy.
And as long as we got a high vaccination rate up here in Minneapolis, in this area, it's unlikely that we could have the same problems they're having down there in Kansas City and St. Louis.
It's much less likely. The problem is if you look at how the surges happened across the United States, they kind of originally started on the coasts and then moved to the Midwest. Then the next surge started in the South and moved up. So we may be seeing this in a couple months from now, where we start seeing a surge in the cities also. But as of right now, it's nothing compared to what's happening nationally.
Yeah, okay. That's it.
All right. All right, guys, we'll keep working hard in rehab and have a great day.
Thank you so
Okay.
much.
All right, bye-bye.
Bye.
Bye.
Thank you very much.